Okay, thank you. I'm going to be talking about the paradigm of sudden death prevention in HCM and the selection of high-risk patients. Over the last 30 years, sudden death risk stratification in HCM has been at times a source of controversy and confusion. I think we can all probably agree with that. And so I'd like to try and simplify this very important aspect of HCM management for you over the next 25 minutes. And I think to do that, it's really important to understand an important principle here, which is that in a complex heterogeneous genetic heart disease, HCM, with a very low sudden death event rate, there's never going to be a perfectly reliable risk stratification strategy, a strategy where we're able to identify all the HCM patients that need an ICD and all the HCM patients that don't require ICD implant. That kind of aspiration is just simply impossible to achieve here in this situation. And so for that reason, because we're unable to really apply a perfectly reliable risk stratification strategy, we really need to think about risk stratification in HCM in terms of a balance. And I'm using the example here of a seesaw. And what I mean by that is that if any risk stratification strategy or tool that's applied to this disease will ultimately place greater weight on one end or the other of this seesaw. So either greater weight, priority on preservation of life, protecting as many patients as possible from sudden death and accepting an increase or upwards of the seesaw here with ICDs and complications, or the risk stratification strategy will, by its very nature and design, place greater weight on the other end of the balance or seesaw with less ICD implants and complications, and in turn, accepting there a greater number of sudden death events. This is the paradigm that we are faced in terms of applying a risk stratification strategy in HCM. So if we understand this, then we can kind of move forward with a better understanding and relating to how to best approach risk stratification strategies in this disease today. And in that regard, the recent 2020 AHA-ACC HCM guidelines published last fall advanced a risk stratification strategy for HCM that was viewed to the greatest likelihood for preservation of life for the HCM patient population. In other words, a risk stratification strategy that placed greatest weight on this end of the balance or seesaw. And again, by putting greatest emphasis or weight on preservation of life, accepting that there would be an increase in devices and potential complications on the other end to achieve this predominant or primary goal. And this is the risk stratification strategy that was predominant in the recent guidelines. It's based on the identification of one or more non-invasive major risk markers shown here, family history of a close or first-degree relative who's died suddenly from HCM or judged to be likely due to HCM sudden death. Unexplained syncope, usually that's syncope that's considered to be arrhythmogenic, trying to do your best to exclude neurocardiogenic or vasovagal syncope. And it's usually syncope that's recent to the time that you're evaluating the patient, where more remote syncope that occurred years from the time of evaluation is much less predictive of sudden death. Multiple repetitive non-sustained VT on ambulatory monitoring, and massive left ventricular hypertrophy anywhere in the LV chamber of 30 millimeters or more. In addition, and I'm going to talk about some of the strengths, some of the other additional strengths of this stratification strategy, but one of them, which is obvious right here, is that it's flexible. It can incorporate new risk markers as they emerge, and they have in this disease over the last decade or so, because studies have demonstrated their association with an increased risk of sudden death events in this disease. And those three newer risk markers incorporated into the recent guidelines are LV apical aneurysms, the high-risk subgroup that have patients that have developed that, extensive scarring identified by a contrast enhanced MRI as late ganglion enhancement, and systolic dysfunction, EF to less than 50%. I'm going to talk a little bit more about those in a minute. It's also important to underscore that abnormal blood pressure response to exercise, which was part of the last 2011 AHA-ACC HCM guidelines, is now out as a risk marker, largely due to its low positive predictive value. And so the principle here is that one or more of these major risk markers may be enough in an individual HCM patient to consider that patient's risk for sudden death to be increased enough that it would in fact be reasonable to consider primary prevention ICD therapy. Now, those risk markers I just showed you are most applicable to young middle-aged HCM patients because as HCM patients age, risk for sudden death decreases significantly. Here's some data showing you that when HCM patients achieve age 60 years or beyond, sudden death event rates are very low, 0.2% per year, probably no different than the sudden death event rate in the general population. And that includes patients that are older than 60 who have one or more of the major risk markers. And so for that reason, the bar for considering primary prevention ICD therapy in an older HCM patient has to be and should be much higher than younger or middle-aged HCM patients. Now, I want to talk a little bit more about some of the particular strengths of the AHA-ACC risk factor strategy, and I alluded to one just a minute ago, which was its flexibility to incorporate new risk markers that emerge. And that, in fact, has been the case. Upper part of this slide showing you the high-risk phenotype of HCM patients who develop at some point in their natural history apical aneurysms. And you can see that here, thin-walled akinetic apex that takes up gadolinium. And so it's a fibrotic scarred rim. And it's the interface of this fibrotic rim and the myocardium that is a nidus for the generation of ventricular tachyarrhythmias. And a colleague of mine, Ethan Rowan, put together some important data looking at the natural history of HCM patients with apical aneurysm, showing here that sudden death event rates are significantly increased in patients with this phenotype, almost fivefold greater than HCM patients without aneurysms. In addition, I should also mention that the aneurysm is also a nidus for clot formation and the risk for thromboembolic events. And so in addition to primary prevention device therapy, the other management consideration for these patients should also include blood thinners or anticoagulation agents to protect against stroke. HCM patients who develop systolic dysfunction on the bottom half of the slide is a process that we define as EF of less than 50%. And that is, in fact, a subgroup of patients, probably less than 5% of the HCM population, who develop systolic dysfunction at some point in their natural history, a process driven by myocardial fibrosis, often extensive scarring, which causes the adverse LV remodeling, which often can include LV cavity dilatation, wall thinning, with the unifying criteria for systolic dysfunction in this group of patients being EF of less than 50%. And as you can see, Ethan Rowan as well putting together important data about the natural history of HCM patients with systolic dysfunction, again, showing you that sudden death event rates are increased significantly in this subgroup of patients. Again, probably largely due to the abnormal substrate of fibrosis, again, providing another nidus for ventricular arrhythmias. In addition, these are young patients often who develop this, who will require advanced heart failure therapy, sometimes even heart transplant, and therefore the need or rationale to bridge them to a definitive heart failure treatment is obviously really critical. And so it's very reasonable for all those reasons to consider primary prevention device therapy for these patients. In addition, extensive myocardial scarring identified as late gadolinium enhancement. You can see two examples of the extensive scarring by the uptake of gadolinium, with bright areas of late gadolinium enhancement identified by the arrows here, which can be quantified in individual patients and expressed as a total % of the LV mass. You can see in the upper right that initial cross-sectional studies in HCM showing a significantly increased risk for ventricular tachyarrhythmias in HCM patients with LGE or scar identified by MRI compared to those HCM patients without LGE or fibrosis. I should mention it's about 50 to 60% of HCM patients who have some LGE or scar identified by MRI. And ultimately, this cross-sectional data showing you that LGE was likely representing the substrate for ventricular arrhythmias in HCM led to prospective studies, one of the largest in the bottom right here from Raymond Chan, showing you this was a multi-center study with US and European HCM centers, showing in about 1,300 HCM patients followed for several years that extensive LGE was a strong independent predictor of future sudden death events, almost twofold greater with extensive LGE than HCM patients without scar or LGE absent. It's also important to point out that if HCM patients have no scar, which is the top bar here, adverse events are very low, and that's a reassuring point to tell patients as well. So extensive scar, a very strong independent determinant of sudden death events at this point now to an HCM. It's important to point out and underscore that these are newer risk markers. And for that reason, we're not able to have been incorporated into versions of HCM sudden death risk scores. So those risk scores that are available for HCM do not include high-risk apical aneurysm. They don't include systolic dysfunction, and they don't include results from MRI, including extensive LGE. And that's really important because, in contemporary cohorts of HCM patients, 20% of appropriate shocks for VT or VF are in patients that were implanted with a device because of one of these newer high-risk markers. Physician judgment and reasoning. And despite the proven value of these individual risk markers that I just showed you, there's obviously ambiguities or gray areas that can still arise. And that provides, I think, an important opportunity really for selective, what I call selective physician-based medical judgment. And there are many potential examples. I'm showing you 3 areas where that could be most applicable. For example, young HCM patient with a maximal wall thickness that approaches massive left ventricular hypertrophy, so 28, 27 millimeters. Syncope, judged by the physician based on the clinical history and the circumstances to be more likely to be arrhythmogenic or more likely to be more benign, neurocardiogenic or vasovagal. Very important in determining the significance of syncope in terms of risk in HCM. And patients that, have all kinds of different results on ambulatory monitoring, including some patients that can have very fast, long episodes of NSVT that may be given greater weight as a risk marker than 1 or 2 short, slower bursts of NSVT, 3 or 4 beats. And so that ability to provide physician judgment and reasoning in terms of interpretation of the ambulatory monitor also really important here. And that has to be contrasted to the risk tools, which are, by their very nature, how they are structured, they are binary tools. So you have to essentially say yes or no to different risk variables. And based on the example I just mentioned, non-sustained VT, it's either yes or no. So it doesn't really provide the opportunity to provide that kind of physician judgment in terms of a patient that may have a very long, fast run, 28 beats of NSVT at 210 beats per minute. That is weighted the same as a 4-beat run at 130 beats per minute. And so these risk tools that rely on binary input of clinical variables are by very nature kind of more restrictive in being able to incorporate, for those reasons, physician judgment. Again, so important in a heterogeneous disease like HCM for all the reasons we just discussed. In addition, shared decision-making. And regardless of whatever risk stratification strategy one chooses, there will inevitably be HCM patients that fall into a gray area, somewhere between high and low risk. And in that situation in particular, engaging patients with the available evidence in terms of what their risk may be, balanced, of course, with the benefits and complications of treatment, in this case, long-term device therapy, is really, really, really critical. Full disclosure, informed consent to allow patients to make the best choice that they can, fully informed about the treatments. And so risk stratification in HCM is one situation in particular that requires fully informed patients and a measure of physician judgment in shared decision-making. And when we look at the risk tools here in terms of shared decision-making, the way they are structured is that they assign a treatment recommendation. For example, on both ends of the risk tool, low risk scores or risk estimates are assigned a treatment, ICD not indicated, where higher risk scores are assigned a recommendation where ICD should be considered. And so that, by very nature, makes it very difficult for physicians to deviate in any way from those recommendations that are being assigned directly to the risk estimate. And that's important because there are some patients, for example, who may consider risk in the high-risk group here to be not high enough for them in any way to consider device therapy. And so by assigning these recommendations about device to the risk level, it inherently makes decision-making more restrictive and in some ways more difficult to implement true shared decision-making for that reason. It's also important to point out that these HCM risk scores or tools have not yet been validated in prospective manner studies to assess the reliability of the score with respect, I should say, to individual patient outcomes. So generating the score with a patient that you're actually seeing and then making a decision and following those patients over time to determine whether we really can know, and we don't know, and for that reason, the actual effectiveness of the risk scores in terms of ICD decision-making and, equally important, sudden death events in a HCM population. They simply have not been evaluated in a prospective manner this way. Now, I also want to, of course, talk about outcome in terms of sensitivity and specificity. And I'm going to use, in terms of one example here, a large US center experience of over 17 years, 2,000 consecutive HCM patients implanted with devices based on that strategy that I've showed you, the ACC-HA major risk marker strategy, where one or more of the major risk markers leading to consideration for primary prevention device therapy. And what we found in this study was that applying that risk stratification strategy to a large cohort of HCM patients over, again, a 17-year period, 82 patients had devices that appropriately delivered therapy for fast VT or VF, which was 50-fold greater than the patients that died suddenly. And any patient that dies suddenly in this disease is a tragedy. There's absolutely zero question about that, of course. But the sudden death event rates were low. 2 patients were actually offered here devices because they did have one or more of the major risk markers, but they declined. 2 were no risk factor patients, and 1 was not advised. So a 50-fold difference between those that were implanted because of one or more risk marker, who had achieved or experienced, I should say, an appropriate shock for what would have potentially been a life-threatening sudden death event. And if we look at those 82 patients then, specifically, who had an appropriate therapy, and we go back retrospectively and apply the risk score to those patients at the time that ICD decision-making was being discussed, about half of them, 50%, would have had low risk scores, and therefore, for that reason, would have been assigned an ICD recommendation for no device, and therefore may have been unprotected from sudden death because of that. 25% would have had intermediate risk scores, and therefore may or may not have had a device, depending on which direction that decision-making led that individual patient. And a quarter of patients in fact, had scores that were high risk and would have likely had devices placed for that reason. So you can start to see here, based on this, the difference in what I'm calling sensitivity between ACC-HA and the risk score. And in fact, there is a major difference in terms of sensitivity between these 2 strategies. And when we talk about sensitivity here, we're talking about, well, specifically the ability to identify the highest risk patients who would be candidates for sudden death prevention therapy with the device. And we're using the ACC-HA major risk factor strategy. Sensitivity is very high, intention to treat of almost 95%, and the risk score is lower at about 34%. It's not just that single large US center experience that shows a difference in sensitivity between the 2 risk models. Here are a number of different studies over the last several years. You can see varying number of HCM patient cohort sizes, different number of sudden death events in these series. And you can see a range of sensitivities for the risk score in terms of predicting sudden death events. If you kind of take an average of sensitivities for all these studies, it comes out to be about the same as the large single US center of about 34%. Now, this lower sensitivity is important because it goes to the issue, again, of predicting sudden death events. And essentially what it means is that more high-risk, unprotected from sudden death without an ICD because of the lower sensitivity issue. It's also important to remember that risk periods are long in HCM. And so there are patients, for example, this is some data showing you that a third of patients implanted with primary prevention device therapy because of one or more of the major risk markers experienced an appropriate therapy for fast VT or VF 10 or more years after device was implanted, 10 or more years. And so that's just demonstrating two things. One, the risk periods are very long in this disease. And so we have to consider that when we're talking to patients and also following them in terms of device maintenance and therapy. And two is that studies that have short follow-up periods in terms of risk prediction are probably limited in terms of what we can extrapolate from that, because you're not capturing the overall impact of these risk markers in terms of identifying high-risk patients if follow-up is short, because patients' risk period is, in fact, as I said, so long in this disease. You really need to extend follow-up out many, many years to really appreciate as much as we can the impact of how these risk markers lead to protecting lives in this disease. Now, is there a cost to greater sensitivity? And the answer is yes. And that's specificity, the ability of the risk strategy to detect patients that are not at risk for sudden death. And in this regard, the risk score tools have a higher specificity than the ACC-AHA risk factor strategy. And that translates into perhaps a small, modest overtreatment of devices if one uses the ACC-AHA risk factor strategy compared to the risk score. Of course, there's potential complications that could come with that. But that is being done, again, at the benefit of higher sensitivity for the ACC-AHA versus the ESC. And in terms of ICDs and complications, is obviously a very important issue. It's obviously incredibly important and central to recommendations that we're making with patients when we're talking about this. But also it's important to balance that out with that inappropriate device lead complications have decreased significantly over the last 10 to 15 years. Decrease in appropriate device shocks related to largely advances in programming of these devices. And the current inappropriate shock rate for devices in HCM patients is about 2% per year. And lead complications have gone down based on advances in the technology of the leads themselves, but also advances in the devices. We're now able to provide patients the option of sub-Q ICD, so-called leadless devices. And therefore, the device complication rates are lower now. They're 1% per year. And then also to mention one point about quality of life, when that's been looked at here in terms of the impact of devices on the mental health and well-being of HCM patients, there is no clear evidence at the moment that, based on those studies, that there's an excess impairment in the general psychological well-being of patients with HCM. That doesn't mean that there can't, of course, be individual patients that are weighted, feel enormous weight psychologically because of the device or because of an inappropriate shock or appropriate shocks in that situation. But it's also important to balance that out by considering that there are also many patients who derive an improvement in psychological well-being, knowing that they are in fact protected from sudden death with their device. It gives them a lot of reassurance, as well as their family, that they are in fact protected no matter what happens to them in life going forward. And so one other final question that comes up is, can you use both strategies that I've been talking about? And the 2020 ACC-AHA HCM guidelines did weigh in on this. And what they said was, select HCM patients who have one or more of the major risk factors and who feel that it would be helpful to have some understanding of what the magnitude of sudden death risk may be for them, that it's reasonable to calculate a risk estimate for them so that they can understand better perhaps what that magnitude or quantity of risk may be for them, not assigning a recommendation when you do that to device or not. We've already talked about how to do that, but to help round out the edges in terms of understanding a little bit better for those patients that feel it may be important, the magnitude of what that risk is that we're talking about for them. But important caveats, that were raised in terms of what the guidelines said here too, was that, of course, when you do that, these risk estimates don't apply to some of the highest risk patients with HCM in terms of sudden death, those less than 16 years of age. Doesn't apply, of course, to patients that have apical aneurysms, extensive scarring, or systolic dysfunction, because those risk markers have not incorporated into risk tools today yet. And we don't, importantly, have any interactive shared decision-making tools that have been validated to help assist patients and doctors to really best understand how best to really interpret and contextualize these risk estimates. I'll just, by personal experience, tell you that it's very difficult sometimes for patients to really, and some of the physicians, myself included, to really relate to what magnitude of risk we could be really talking about, particularly differences in risk between, for example, 1% per year, 1.5% per year. It'd be very difficult to, some ways, express that difference in risk in a way that both physician and patients can contextualize it in terms of decision-making for devices. So it can be done, but there are a lot of limitations to consider when doing that strategy. So finally, the individual clinical risk factor strategy incorporating physician judgment and shared decision-making reliably predicts sudden death and substantially reduces catastrophic arrhythmic events in HCM patients. And that has resulted in a large part helping to reduce significantly the overall mortality over several decades now in HCM from early cohorts of mortality rates of 3 to 6% per year, which decreased to 1.5% per year with the the emergence of some contemporary cardiovascular treatments, and then current contemporary treated HCM cohorts have a mortality now that is very low, 0.5% per year. Obviously, we need to get that lower, but that itself is very low, and it's being driven by the implementation of a number of contemporary cardiovascular treatments, but one of the most important is the risk stratification strategy using the AHA-ACC risk factor strategy I showed you, with, of course, the ability to protect those patients with ICD therapies. On that note, I'll conclude by saying the ICD-HCM is proven to be effective and reliable in nearly all HCM patients and responsible for changing the course of the disease now with very low mortality. There will never be a perfect risk stratification strategy in HCM, so we're going to have to make a decision about which side of the balance we want to align, either higher sensitivity or higher specificity. And the implications of those choices in terms of selection of high-risk patients for ICD is most effective using the AHA-ACC risk markers, meaning it's more sensitive, it's the most sensitive, incorporating, of course, physician judgment and shared decision-making. But when you do that, you really do have the opportunity, in my view, to identify nearly all at-risk HCM patients for sudden death prevention with device therapy. Risk scores provide higher specificity and the potential need to avoid some unnecessary devicing. Thank you very much for your attention. I appreciate it, and I look forward to helping answer any questions that may be asked. Thank you very much.